All set?
Good afternoon, everybody. Thanks for popping in on this discussion that we're going to have. I'll pull up slides for us to look at here in a couple minutes. But to just get started, for those of you who don't know me or I haven't had the pleasure to meet you yet, my name is Lynn Braun. I'm the Director of Counseling Services, and I think next week will be about a year since I've been here at SUNY Oswego, which feels like a month in some ways and 10 years in others. So I don't know if that's good or bad. I think it's just the way things are at this point, probably for most of us. But I have really enjoyed my time here so far, and look forward to this conversation that we're going to have. We're going to talk for a little bit today about the mental health crisis in higher ed. And at the end, I will show you kind of the reference. We're doing this for several reasons. But part of what's going to inform this paper is I am on the board of the Association for College Counseling Center Directors, College and University Counseling Center Directors at UCCCD. Actually, I'm president-elect of that organization now, but last year co-authored a position paper for that organization on how to navigate a path forward for us in collegiate mental health. So part of it's going to be informed by that and many other things that have gone on kind of in our universe here in the last 13 years that I've been back in higher ed, but we're going to look even a little further into about the last 2 decades as to how we got here. But to get us started, what would be helpful, and I am going to ask you to participate a little. I know that on Zoom that can get hard, and if there are a lot of people on Zoom that can be harder, but we're going to try. I'm first just really curious what brought you here to this presentation today and what you're hoping to hear so that it can help shape maybe where I go as we converse over this next hour or so. So if folks want to either unmute and share, or if they want to pop something in the chat and share, I think either way is fine. But if you'd share a little bit about what had you sign on today, I think that would be real helpful for me.
I could go first.
Absolutely.
My name is Lizette Alvarado from the Office of International Education and Programs. I work primarily with outgoing students, education abroad students. So just to learn any tools that I can to better assist students as they prepare for study abroad. And also to assist our resident directors overseas and better prepare my coworkers on mental health, really.
Thank you for that.
Yeah.
You can see some things also in the chat, learning about others' experiences, concerned about student welfare, concerned about growing number of student concerns, better ways to support students. I will say that some of this is probably better covered by the presentation I gave last week, which I think there's a recording of, on how to manage distress in students. So let me just say that to you, and I'm also happy to come in and talk to you and your staff or your department or whatever about those issues at any point. We're going to cover that a little. We're mostly going to talk today about this concept of there being a mental health crisis. Okay, and really whether there is one, I guess, is what I would say to you. And so the first big question that I, beyond the, what are you hoping to get, that I had to ask really today, and is there a mental health crisis in higher ed? And if you think so, why? Anybody have a thought about that?
So I'll jump in there. I'm not sure in terms of crisis. I do think we have a crisis in responsiveness, that our institutional structures and the experiences of us folks who may have been around longer, that we're not adapting to the different ways that students are presenting and talking about our mental health. So I think there's a mismatch that is like becoming crisis level in terms of the actual student experience. And that's what I want to hear about from you. So
Okay, that's helpful. There's some other there's some other things that have been happening in the chat. Harder for students to make decisions, absolutely. Mindset that things aren't supposed to be hard, or maybe that everything's hard. I'm not really sure. Maybe there's that piece of it that maybe you were speaking to there, Lisa. You know, Peter, I think you're right. There are mental health issues that were exacerbated by COVID. I don't know how long all of you have been in higher ed, but if you've been in higher ed for the last 2 decades, we've been saying mental health crisis for about 20 years in higher ed. That presents some problem for a whole number of reasons. And I'm gonna pop over to my presentation I have for you a little to start to talk about that. There, I think everybody hopefully can see that. Let me pop my other screen up so I can see all of you. It's hard to keep that and chat and all of that in the screen at the same time. So I appreciate your patience here for a minute while I move all that over. Okay, so we have to start by talking about what a crisis is, right? To decide whether we're in one. And if you really look at the definitions of a crisis, it's a stressful situation that caused difficulty in coping. Okay, from our mental health landscape, that's what we're going to call crisis. Merriam-Webster calls it an unstable or crucial time or state of affairs in which decisive change is impending. Crises are relatively short term. Does that make sense, David? I know I can't see all of you. Some of your video muted, but for those of you who can, I appreciate the visual response. Actually, I was reading a study the other day that was studying lengths of crises for people, and I think that they assumed it was weeks, but actually did find that for some people there could have a crisis that has a longer term effect of up to like 7 months, right? That somebody could have experienced something traumatic enough to have caused a crisis that could last that long. Does that make sense? We have been talking about this in higher ed for 20 years. We're going to talk a little about the history, and I say all of that to head to this, to kind of maybe I've probably already front loaded my position about this, but we are not. I don't think we are in a mental health crisis, and I think we have to quit talking about it that way for a lot of reasons that I'm going to talk about here in just a second. And it doesn't mean that we don't have issues we need to manage. By the way, it doesn't mean everything's going great either, if that makes sense. But it does mean I think we need to change how we talk about it, because I think that also changes how we manage it and move forward too. So the mental health crisis narrative currently, though, underemphasizes resilience, right? We don't focus on resilience currently. We are downplaying the importance of typical stressors during early adulthood. We are focusing on pathology, right? The mental health crisis narrative focuses on people being mentally ill in large part, right? And that because of that, they need mental health professionals, number one, to address whatever those issues are. And we are kind of minimizing, ignoring what we would have maybe to some degree, even 10 or 15 years ago, called normal college experience. And what we've done is mild, moderate, and everyday stress is now pathological and now requires significant intervention to mediate. Does that make sense to folks? That's been part of what's happened, right, as a result of this narrative. Now, how did we get here? And it's never ending. It's never going to end. If we look at how we got here, it really started about 20 years ago. So if you have been in higher ed for that long, or I guess even if you haven't, just to get a little history, we started to see a rise somewhere around 20 years ago in the mental health world, at least in higher ed, of an increase in the number of students seeking services and the severity of their concerns. Also happens to be that around that time, the way in which we were admitting students changed too, which, by the way, I don't think was a bad thing. I think that it was around 20 years ago that institutions started admitting students that previous to that might not have been admitted. So we opened the doorway to who could be college eligible, right? And who could have access to a college education, which was wonderful. But it also means that a lot more of those students came in with stressors and difficulties that maybe previously would have kept them out of the college sphere and might not have had them thinking about college. And thankfully, we widened some of that, and they were coming. And at the same time, in the last 20 years, we've had an increase in understanding about what mental health is, right? And that it's not a problem to talk about it, and the stigma of those things started to be reduced. So we have a lot of things that have come together to start to see this rise. What happened in my field of college mental health is, for a while, folks started to think that that would be temporary, that we were just seeing this kind of temporary influx that everybody was adjusting to, but assumed at some point it would kind of go back to what they at that time would call normal. If that makes any sense. And I know a lot of higher ed admins and professors. It wasn't just in the collegiate counseling world that we were saying that there was this sense that we were having this little wave, we would ride it and things would kind of level off. By the time I re-entered higher ed 13 years ago as a counseling center director, and went to my first national conference of college counseling center directors, what they were talking about then is new normal. That we now had a new normal, that the thought that we were going to go back to pre-20 year, to pre this wave wasn't going to happen, that this was now going to be the state of things, right? That we were going to have and experience a higher severity and more students seeking service. So what were we going to do about that? And I think that not just in college counseling and not just in college counseling center directors, but institutions started to get that feeling to some degree as well. And we also, at the same time, in that first decade, if you look from 11 to 20 years ago, saw increased in completed suicides, saw more tragedies on campus. Virginia Tech was 2007. So we started to see more mass shootings that started to happen after that, and lots of other types of crises that were happening on campus that was adding to the distress. Centers and campuses started getting overwhelmed with need and needed resources. And we're scrambling with how to get resources, as we still are. And you also had then a mental health industry at the same time that was really impacting the way in which we diagnose because of third-party reimbursement. And so, you couldn't just have an adjustment problem and necessarily go to therapy and get help for that and get that reimbursed, right? So we had to start diagnosing people or pathologizing things that, quite honestly, prior to that, we might not have pathologized so that people could get assistance and help. Now, that didn't affect the college mental health world much because most of us don't bill, but to be trained to see a system that overall is heading that direction, it's impossible for that to not impact the collegiate system, if that makes sense. So it's part of why you saw more and more students coming into college with diagnoses than you ever did before, partly because it's not that they weren't having those issues prior to that, we just wouldn't have pathologized it prior to that. And some of those issues were contributing. And because we saw what was coming and happening to us all as a crisis, we reacted. Now, I will tell you that the colleagues that I work with, I'm going to show you an image now that for us, this is not a reflection of SUNY Oswego. This is a reflection of the entire movement, in our opinion. It looked a lot like this. We kind of have played whack-a-mole, in essence. Lots of institutions have for about 20 years here, trying to figure out how to manage this thing, right, that happened and has been happening, that we kind of are just hope it goes away, but it isn't. And so we've all are just trying to figure out how to capture that, if that makes sense. And so crises, the other problem with the crisis narrative is crisis implies a reaction. So we got out of proactive mindset, if that makes sense. The institution, most institutions did. And so it was, okay, how are we going to solve this immediate problem? not seeing it as how are we going to, in a proactive, longitudinal way, deal with what is now going to be normal for us all, right? How are we going to manage this in the long term? And so some other things happened in this 20 years of reacting now. So we have seen increased advocacy by providers and administrators for increased funding. And quite honestly, I have to admit, and college counseling center directors will have this conversation, we've done some of this to ourselves, right? That higher ed admins and college counseling center directors benefited, to be honest, from talking about the crisis because it helped us get funding. Not internally even as much as it did externally, right? I mean, you know, how do you get legislators to understand that you need funding to help address a problem? They respond more to a crisis than they do to a long-term proactive plan, for good or for bad. That whole increased pathologizing, which we talked about, part of that was around too a fear of missing risk. If you put that together with the increased suicidal behavior that we're seeing on campus, right? That, you know, it's how do you interpret things? And so, oh, we're going to err on the side of caution and we're going to pathologize this and call it a problem, right? Call it a mental health issue. Partly because, you know, we didn't want to miss somebody who might be really in trouble. And we started equating these terms, right? Distress started being equated with pathology, started being equated with crisis. And it's led us to a point now where most people I talk to can't distinguish the difference between those three things. You know, and it's been a gradual shift, I think, that absolutely, I think, Peter, you were the one that said it, that COVID amplified, right, to a large degree. We also have a media influence in the last 2 decades where both the 24-hour news cycle, you know, this pay-to-click stuff, the rise of social media, you know, that's been wonderful in some regards, but the reality is, you know, we have normalized this language, we have normalized some of these terms, and people have picked that up. And, you know, I don't know about, you know, I have teenage children, and quite honestly, if it's on YouTube or TikTok, it is true. And I think we're creating an environment, right, where now you can access so much information from so many things that is not vetted, right, in any way, shape, or form. That all these terms, all these mental health terms, are now being used in bigger, general ways, and we've diluted to some degree their meaning. And crisis sells. Let's be honest there too, right? So from a media perspective, it's some, you know, you get more people paying attention to that kind of language. We've also had a rise in competitors and vendors that are vying, you know, to be the savior of higher ed in some ways and to solve these problems. They are benefited by this crisis narrative being fed. And if you look at the materials that a lot of those vendors put out, that's what they're talking about. They are talking about how horrible the problem is and how much help institutions need, and here are solutions for that. And I'm going to say this, there are lots of good vendors out there. It is really just talking about, right, just how the narrative has continued to shape that way. It's not a complete knock on vendors at all. Kind of back to this media part, this integrating psychological terminology into popular culture has misled people, I think, to some of what it means. And what the result of that has been is people are using those terms to describe everyday things that normally would have just been stress or coping problems, right? Or normal everyday things that people go through. We now want to label, right, in some kind of psychological jargony diagnostic way, when previously we wouldn't have. And previously culturally we wouldn't have either. And again, COVID-19 absolutely was an amplifier to some of that. So why is the narrative bad, I guess, is part of this too, right? Why is it bad to talk about it as a crisis? It's got two opposite effects sometimes. In one way, it discourages students from seeking treatment, because if mental health problems are normal, how do I know that mine are something that needs treated, right? We have that happening. We also have, I see lots of students saying, oh, you know, your center is so busy, my problems aren't that bad. when in essence, actually some of theirs are, and they probably do need to come see us. We have this other opposite reaction, which I think is interesting. It's called the prevalence inflation hypothesis, which is where increased awareness has folks interpreting milder forms of distress as mental illness, right? Kind of what we just talked about on the previous slide. That the more we talk about something, the more I recognize it sometimes in myself, even if it's not really there. And we're encouraging this notion that students need psychological treatment for emotional distress. Now, I would say we do need psychological treatment for some emotional distress, but not everybody needs psychological treatment every time they experience emotional distress, if that makes sense. But we're hitting a point where that's a hard line to draw, it feels like anymore. And that does tax the system then, right? So for folks who 20 years ago would have or had the skills, or 10 years ago, or even 5, right, pre-COVID, would have had the skills to manage and navigate a smaller psychological or distressing issue. Now it needs major intervention, if that makes sense, to navigate, which is a problem for the system and really for everybody's individual functioning, I would say too. And absolutely it overwhelms the professional service. So other problems. If we're overstating the number of folks on campus who have really diagnosable mental disorders, we're also trivializing real mental illness that students on campus are dealing with. These are not all the same, right? And so if everybody has mental illness, we are not able to distinguish between folks who truly, really, under kind of what my clinical judgment will say, are really mentally ill and need significant treatment versus folks who are just distressed. Those are two very different categories, and we've got to be able to tell the difference between them. And it really isn't helpful to try to equate all mild distress as pathological. It's not helpful to us at all. So it also positions all students in need of intervention. And if everybody needs intervention, it kind of ignores the ways that we're supposed to try to work on them being resilient. Because we don't all need intervention for everything that goes wrong, right? Sometimes we can figure out ways of managing those things internally and how to build resilience. And so it's a little bit of an over-reliance on treatment and an overwhelming demand for solutions and quick fix kind of interventions. Part of the way we see this is we have lots of students who don't come in for ongoing therapy. They come in for immediate problem solving because something has happened that, quite honestly, at some other point in our past, they would have figured out and managed and used their kind of community and support resources to deal with, and they would have solved that problem and moved on. They now want to come in for a walk-in because they can't manage their emotional distress about it, but they're not wanting to work on something long-term. They're just wanting to pop in and manage that thing and pop back out, right? Which is fine in one sense, but it's problematic in others, right? Because those are folks that a lot of those folks could absolutely kind of relearn or learn how to use their other resources to manage those things and not tax the resources of the institution and the center in a way that can overwhelm it and make it hard to then serve students who are in higher need for longer term kinds of interventions to be able to be successful and remain in school, which is a big concern from a retention management standpoint. Okay. To me, the biggest issue almost is this. I mean, all those other things are very important, but everything currently seems like it's a crisis. I don't know if it feels that way to you. It's sure the way it sure feels that way to me. As I talk to folks, not just from folks who come in the center, but as I talk to folks. And we have noticed pre-COVID actually, but COVID amplified it, this inability to tolerate distress at all. Now, why? And connected to that, a wide-reaching use of these words, crisis, trauma, and trigger. Okay? The higher ed landscape has definitely seen an explosion in talking about trauma and trigger. in more than the last 2 or 3 years. It's been happening actually longer than that. And often it is a means to avoid feeling distress or discomfort. Okay, so to pause for just a minute so that we're all running from the same kind of platform. This is not a presentation about trauma and trigger, but just to pause for a minute. We talked a little about what a crisis is. Trauma are events. Most trauma are crises, by the way. Not all crises are traumas, but a traumatic event is an event in which your system feels like its life is in jeopardy, right? Where your being is in jeopardy. That's a traumatic event. Okay. A trigger is experiencing something that reminds you of a traumatic event. Okay. So it triggers that traumatic response. Now, for example, the conversation I had with a student shortly before I left my last institution, who had a class that was talking about, I think that they were doing a special topic on genocide, and they had come in talking about how triggered they were, and I had to have some conversation with them about, no, you're really upset. You're not being triggered. Why? Because they don't have a history that's in any way connected to that kind of trauma, right? But it is super distressing to hear about, and it is super upsetting for them to have to hear about and talk about. But it doesn't mean that they were triggered, because they don't have a past trauma to get triggered that's connected to that, if that makes sense. Now that's slightly semantic, and I'm not saying you got to argue with every student about whether they're triggered, but these words do mean something really specific. And if we don't figure out a way to start edging back toward what they really mean and not generalizing them to everything, then it dilutes people's experience. It dilutes the experience of a person who really is triggered by something versus somebody who's just upset at having to hear about something, right? Or that finds information upsetting. So, as I talk to folks on campus, both here and other places, a lot of what I hear is this inability to tolerate feedback. I don't know if you are experiencing that, but that we have more and more students who are having difficulty just kind of managing what I would consider normal feedback, performance feedback, or how they're doing on an assignment or on a in their job if they're working on campus or other things. That oftentimes this distress, I think, is perceived by some, and I think sometimes probably accurately, to be a way to stop feedback and to shift focus of feedback. So if you're trying to give me feedback and I get super distressed, we now have to focus on me not being distressed, if that makes sense. And I, in some ways, can avoid, at least temporarily, right, whatever this feedback is going to be. And we're in this interesting mode where I have worked with lots of trainees and students who know it's fascinating to me, because they know they don't know everything. They know they have a lot to learn, but they can't tolerate the feedback of it to learn it. Right? So it's not like they're narcissistic and think they know everything and that they don't need you to teach them anything. But the fact that you're going to give them feedback about what they need to change causes distress, and that lots of them don't know how to manage, and makes them seem like they don't want feedback. When in the end, it's for some reason at this point, they're having trouble taking it, right? They're having trouble tolerating the distress it creates that they're messing up or not doing something well, or whatever that means in their own head. And so I don't know if you are seeing that, but we're seeing that in a pretty significant way. Josh, yeah, I saw what you chimed in there, Josh. Yeah, I think there are some liability kinds of questions, right, that have made people really afraid to just handle something, right? That you have to have a professional, right, to be the gatekeeper of that, right, from a liability and risk standpoint. I think that's true. I would say this inability to tolerate this distress, that the crisis narrative actually impedes learning. You cannot learn anything without some discomfort. To me, it's part of the learning process, right? And sometimes the more uncomfortable I get in a moment, or the more I have to struggle through something, the more I end up learning, right, on the coming out of the other side of it. And that folks' inability to tolerate that feeling is, in my view, really getting in the way of students' ability to reach their potential and to learn as much as they can. And that I see lots of students trying to avoid those experiences, which in essence is restricting how they can learn and grow, because they don't like the feeling of it. Any thoughts about that? I guess I'm curious if that's something folks are seeing and hearing. Am I just in my little bubble over here and seeing it, or is that something that folks are feeling as well? I see a few head shakes here from the couple of you that are on they're on. To me, the other point at the end of this is this: does the crisis ever end, and when? Right. The other problem with calling this a crisis is where's an endpoint? So it creates this, and that's what's happening in the system. You create a system that is hopeless and in some degree helpless, because if this is never going to end and nothing we've done is ending it, then what is there to do? Thankfully, I don't think it's hopeless or helpless. I don't think we have to be helpless about it, because I don't think we're in crisis. And I think we have to stop thinking that we are and believing we are as a part of our moderating for students that we're not there. Because lots of times what a student needs to kind of feel and hear is like, you're not in crisis. It feels like a crisis, but this is something you can manage and we can manage, right? I would say the same thing about this. We are not in a collegiate mental health crisis, because this is something that we can deal with and manage collectively. And we're going to talk about how in some ways. Thank you, Lisa, for that feedback there on the chat with that little bit of agreement. We did two things that led to this hopelessness, at least in my profession, and I think to some degree institution-wide. We started saying we can't hire our way out of this, because the initial whack-a-mole approach early on was to just add staff. That adding staff would be the solution. And don't get me wrong, it is super helpful. But, in lots of institutions, we've been pretty fortunate. At least in my tenure in recent past, we don't have waiting lists, right, or things like that, for reasons I'll talk about in a minute. But in lots of institutions, they were having these long waiting lists. They started hiring staff, and it didn't change the waiting list, because the more staff they hired, the more people that came, right? Because as visibility increased and as staffs grew, more people came out of the woodwork. And so we started this narrative, and actually it's one vendors use a lot, which you can't hire your way out of this, so here's some external resources. Well, it would then lead to this: we can't meet the needs, right? And what I would say is those are interrelated, and part of what I'm a real advocate of now, I think I actually talked about it in my interview, some of you were there over a year ago, is, oh, sorry, you're going to hear probably barking. I apologize. But what we have to do is we have to be focused on, we can't meet all need. But the way we get proactive and get out of this is deciding what need are we going to meet. Because if you decide on the need you're going to meet, you can hire for that, right? You can create a plan to manage whatever that need is you're going to meet. But it is probably true that you cannot meet all needs, if that makes sense, right? So what are the institutional priorities going to be? So how do we stop it? How do we stop the narrative? The first one really is to quit panicking, and when you hear other people talk about how horrible it is and what a crisis we're in, is to stop and go like, slow down. Like, yes, we've got problems, but we are not in crisis. Okay. So we do not need to panic. That is the first part of it. And at any time we're doing any type of debriefing, one of the first things we talk about is just stop and breathe. And so in this way, in some ways, we just need to stop and breathe a little bit here. Part of it, and you all are doing a good job of this now, we have to recognize it exists, and we have to recognize the impact it's having on not just our students, but ourselves and how we're navigating issues on campus. We've got to make sure that we're educating ourselves in the campus about what normal human experience is, right? I talk a lot to faculty. Actually, there's some RIT, Rochester Institute of Technology, the former director there, David Reitz, was doing some studies probably 6 or 7 years ago that were fascinating. He and I have some of this. If any of you are interested, feel free to email me and I can send it to you. They did a study, but what they really started to do is they had some faculty who on the first slide of every course would it's a small paragraph about that struggle is normal, that you're going to struggle in this class sometimes. And when you struggle, you need to reach out to me because my job, right, is to help you navigate that struggle and work through whatever problems you're having learning, basically. That's a pretty simple message. What was interesting is they had some folks put that on their slides and they had some professors not put it on their slides. And I think about halfway through the semester, they did a survey of students about the perception students had of their faculty and whether they cared about them. Fascinatingly, for the faculty that had a simple statement like that on their slide, and they read it twice, two different class periods, about struggle, students felt like those professors cared about them more. Now, that takes almost nothing to do, right? But that is one really simple example of how you can normalize human experience, right, in your class, for example, if you're a professor. Or how when I talk to students and talk about, yeah, you're going to have trouble with your roommate. And that's part of what it means probably to be in college. And you're sometimes going to have trouble with your friends, or, your significant other is, it's not always going to be great. Fortunately or unfortunately, that's part of navigating college is being in a safe environment, right, to learn how to deal with all these adult things that are going to happen to you, where you have a lot of support that can help you from lots of different avenues. If we could start normalizing that can make a really big difference in this, because then when people start to experience something, they go, oh, right, yeah. When I start to struggle in my class, I have a student who goes, oh, right, they said this was gonna be hard for me sometimes. Because we have a smaller proportion, at least in my experience so far, than I did at my last institution, but we have a good chunk of students who quite honestly aren't even sure they're cut out for it. And so when they start to struggle, they don't know how to interpret that. For some, it's the sign that this wasn't for them. Whereas for most of us, we're like, oh no, that's the sign, right, to go get some help or to get a tutor or to figure out how to work through it. For everybody, that is not what it is. If you're already insecure or uncertain or stressed or struggling in other ways, right, you take it as a sign this isn't for you, right? And that there must be something wrong that you're struggling, because we all think that nobody else is struggling and only we are, right? That's another kind of part of our DNA a lot of the time. And so really figuring out ways of normalizing those things, and even talking about coping and support. I try to find really subtle ways of talking about how, my kids and I talk about this. I talk to my students about this. I mess it up a little bit every day, right? None of us are perfect. We all mess it up a little every day, right? It's more like the hows and the whats, right? Do I just not mess anything up too big, and do I make sure I do what I need to do, right, to repair or fix or learn from it, right, and move forward? And so finding even small ways of being human in those ways, right, is a good model for students about how to cope, right, how to access support. If I don't know an answer to a question, me modeling finding somebody else who knows and not getting all upset that I don't know, right? I think most of us do that, but those are all important ways of modeling for students how to kind of navigate these things. It normalizes the struggle, and it doesn't label it as some kind of mental health condition, right? Because a lot of these things aren't. mental health conditions. If you're having trouble on quitting the panicking, really just stop and like, is this really a crisis and why? This moment you're in, right? Or the student's in. You don't need to ask them, right? Because they're going to feel like it's a crisis. Emotionally, it feels like a crisis to them if they're coming to you that way. So it's not arguing that for them, but it's also us not getting sucked into that, right? How do I then just help them calm down and breathe and take a minute so we can problem solve instead of having to do some higher level intervention? Crying does not equal crisis. And we have gotten in a mode to some degree where if we're crying, I mean, I will say this, I do not think this happens as much on this campus as it does other places. Thank you all. I'm going to thank you for this in advance. But, I hear from lots of directors about how anytime a student cries on campus, they're getting called to come and intervene. And I don't think that is happening here, by the way. Again, I thank you all, for that part of it. But we are sending the wrong message to students, right? Anytime they get distressed at all, that they need a counselor to come and help them get things together. Again, it's that pathologizing piece. Sometimes they need us, but normally they don't. And this is the other piece. And I know that the legal piece can be, an issue. And if we're not going to talk about that a lot today, but I'm happy to come and talk to you, your staffs or departments individually about it. But you all have skills. All of us have people in our lives who get upset. And somehow we figure out ways to help calm them down outside of our work life, right? We all have people around us who get distressed or upset, and we figure out ways of assisting that. Those same skills can apply to what we do on campus. I don't have to be a therapist to help somebody calm down and breathe for a minute, right? Or to think about what their options might be. Because a lot of what they're distressed about is in your wheelhouse anyway. A lot of times what they're distressed about is what's happening with them academically or in their living and learning on campus. We do know things that we can be helpful there. And it's kind of okay to remember that we do. That doesn't mean, by the way, you have to solve all their problems. I would argue actually you don't have to solve any of them. And you probably shouldn't. That our job, if anything, is to help them think through options. That's from my last workshop last week. You can go and watch a little, but that our job is sometimes just to help them realize the choices that they have and to be encouraging, and sometimes to normalize, right? Like, it's okay, you can get through this. Here are some options you have of how, right? Is sometimes what our role is. So, we have to, the last thing, I'm going to show you some images. We have to expand our language around expressing emotions again. We have kind of crunched our emotional expression culturally into just like 2 or 3 words. Because it's all like crisis and trauma and so a couple of things to think about. So if you look at this image, this is my favorite emotional images. These are not all of them. I'm going to show you another one that has even more. But these are some emotions. Think about how many of them you ever hear a student say. Or obviously us even, maybe. Maybe we could do a little self-eval there too. Not many anymore. You know what I'm saying? That we need to get better about showing the gradation, because there's a real big difference in me being upset and furious, right? And me being a little annoyed with you and me being completely done with you, right? And infuriated. So how do we start to use these words and help students realize there are a lot of words out there? And that's how I start to understand, right, the difference between a crisis and me being uncomfortable. That's the word I've started using with students a lot. I don't really argue that they're not in crisis, but I'm like, yep, I know you're really uncomfortable. You're really uncomfortable right now. Trying to help model that slightly, right? I don't have to argue it, but, or as I learn more, I try to pull more of these words out, right? Yep, you were feeling really rushed and you got really overwhelmed and right? I mean, I then start to pull some of those to help them learn how to even describe what's happening to them, right? Because it can't all be the same 2 or 3 words. Here's another image that's got even more. I thought this was kind of crazy. So the left are positive emotions and the right are negative ones. See, there's a ton of words out there. But I'll simplify it. Honestly, I'll show you a third one. Even if we can only get to something like this, which is a lot less words, if students could just learn to see the difference in these, right? If we could all, honestly, as a faculty and staff, start modeling the use of a few more words, even like this, right? Then we're in a different spot in how we start to change the culture of what it means to really be in crisis or what it really means to be managing a stressor, which are 2 very different things. Questions about any of that before I head into my next slide? Okay. Here's another image that I think I used actually last week. Actually, I use it almost every time I talk to folks, but here it is. It is helping folks understand this. Right? Your best looks different every day. And because that is based on what else is happening in your life, right? It's based on, heck, what side of the bed you woke up on this morning. It's based on how much sleep you got or what other stressors you have. Normalizing the up and down, and that it doesn't mean the sky's falling, is huge. Huge. That doesn't mean the sky's also not falling sometimes, but that's okay. Honestly, if we could just swing a little this direction, we'll still catch all the sky's falling folks where it's real. We just need to get a few more of these folks realizing you're okay. Here's another image. I work a lot with not just students, faculty and staff too, with everybody on campus, right? At this image, what do I control and what don't I, right? If you look at the indicators on happiness, what all the happiness literature would tell you is if you focus inside that circle, your happiness quotient increases dramatically. Right? There's a lot of power in really focusing on the things you have power and control over and the things you don't, and figure out how to navigate yourself through those. What most people who I see in the clinical setting have trouble with is they're looking outside, not inside. They're trying to control the things they can't instead of trying to control the one thing they can. And that happens from relationships to all kinds of things. And so I just think this is a good reminder of am I focused on the things that I can really impact and how I can impact them? Because I think all of these things relate to changing that culture. Okay. And again, if at some point you either want me to come in and talk about any of this more, or you just want some of those images, I'm happy to send them to you. Just send me an email and bug me for them. So a little more about how we stop this narrative. We cannot say these 2 phrases anymore. We can't meet needs and we can't hire a way out. You will never hear me say those words because it's just not accurate at all. So we're working on it in some ways. To really work as an institution, we have to have a campus-wide strategic plan for mental health. I would say also in well-being. I think that the overall well-being part folds right into this. I'm talking about it from a mental health standpoint today, but health and well-being folds right into it too. Because the strategic plan lets you focus on what's the outcome you're looking for. Okay. So I'll give you some mental health examples or some college counseling center examples. Some institutions, their goal in the ways they want to impact mental health on campus is they see it as a retention management tool, right? They want to make sure students are getting what they need so they can stay well and able to focus on their school and continue in school and graduate. Okay. If that's an institution's goal, that takes more resources because that means you need to be able to see some students more consistently, right, who have significant mental health issues. You've got to be able to manage those folks and see them sometimes for a while. And we do know there's a lot of research actually on the benefit of therapy as it comes to retention. There's a lot out there. And so for some institutions, they want to lean into that and they want to invest in that, right, as a retention management tool for students who might fall through the cracks otherwise. For other institutions, they're not concerned about the retention management end, because for some institutions, they don't have that large of a retention management problem, or it's not their priority. And they just want to make sure that if somebody wants to be seen, they're able to have some contact. We call that an access model. Okay. We're in a hybrid right now between access and what the other model we would call, which is treatment. We're kind of in between right now at SUNY Oswego and kind of trying to make some swings a little more toward the treatment side. But what all access is concerned about is if somebody wants seen, they get seen at least once, right? So that everybody gets access. And it's worried less about the outcome long term for an individual, and more about the fact that the contacts are available, if that makes sense. Now, I'm not putting a value judgment on either one of those outcomes. Personally, as a practitioner, I sure prefer one to the other, but any institution can make that call, but you do not resource those two goals the same, if that makes sense. You don't create a center to operate the same based on those two goals. They look very different. And so part of what institutions have to do, and this is what I've been traveling the country at conferences talking about for the last year to all kinds of leaders of higher ed, is you have to decide what's the goal and then figure out if you're willing to resource that to give yourself a chance to achieve it. I mean, we're in a new strategic planning process now, right? Even as an institution, in some ways, we're doing that all across the board. We're trying to figure out what are the outcomes we want, and do we have the ability, right, to create a plan and resource them to a point that we can achieve them. That's very similar here in the mental health landscape. That alignment of all of that allows us to be transparent. So it means that from the point they become interested in contact admissions to anybody they talk about, they hear the same thing, right, about what the mental health service is. Why? Because as an institution, we've kind of agreed to it and we have an objective. And so for some institutions, they're saying from the front end, you may only get to see somebody 4 times, but everybody who needs to see somebody gets to, right? That's more of an access kind of model. Or you're having somebody say, here are here's the decision tree, right, by which, we make decisions about what level of treatment folks get, and we really work hard to make sure that folks who need more service get it, and those who need less get less, right? So equity, not quite equal, if that makes sense. And so again, it's not a value judgment one way or the other, but do we decide and do we communicate that? And that's part of what we're working on kind of as an institution. But that consistent messaging means people don't get frustrated. It means you all don't get frustrated either, right? Because you know what to expect. So that when you access the center or call or send a student, you already start to have a sense ahead of time of what that's going to mean. Okay. And what kind of service and support they're going to get. And so that none of us are promising things that the system can't deliver. Because that's where frustration enters, right? That's where you have a parent call upset because they think their student's going to get one type of service or intervention, and in the end, they're going to get another. Questions or thoughts about any of that? Okay, so I'm curious, and you can unmute and talk about it, or you can type it in the chat. I'm really curious what people's thoughts are as you kind of absorb all of that. That was a lot of information, I realize. When you think about what's a small thing that you see in your sphere, kind of after hearing all of that you think you could start to shift slightly, right? As a part of kind of getting out of this crisis narrative kind of model. Anybody have any thoughts about that?
Lynn, Ramin here.
Yeah.
First of all, I 100% agree. I think we We certainly have students that need regular care, but then we have plenty of students that that are reacting to things that are stressful and overreacting, perhaps. I do want to hear your thoughts about, I certainly have met students that their life story and their perspective about where it's going, I don't have a solution for. I mean, there's just they're coming out of foster care, there's no home to go back to. There is, people have done wrong by them and they don't trust. I mean, there's just so much, but I'm certainly not prepared to say they have a particular diagnosis. I don't think they do. They just have so much that they have difficulty to cope. And that's I don't know if that really fits either of the two contexts.
Well, it does, I would say, and thank you for that. Actually, Friday, I'm talking about the impact of trauma on learning and bias incidents. So this, in some ways, that's really what you're talking about. I would say, Ramin, is we do have lots of folks who come to us who have experienced a lot of really bad stuff, right? Or really a lot of hard stuff, and who have very little support, right? Those factors. I don't care a lot if we can diagnose that from a mental health standpoint, though, right? If you're experiencing a lot of trauma, there's probably a diagnosis in there that would qualify. But how I would personally view it is, and this is where I think we're heading as a center. I look at this from a functioning / retention management landscape, lens. If whatever you're dealing with puts you at risk of being able to stay, we need to be able to provide some resource for that. And that's not a resource that you need to provide. That is then the resource that the center, we have some extra expertise in dealing with trauma and family of origin and all those other issues. Right? That's where treatment can be really helpful. But, coming to see somebody just every other week is not treatment. That to really make progress on some of those things for folks so that they really can start functioning differently, that takes some higher level intervention, because you're looking at people changing fundamentally the way they manage the world, right, and navigate the world. Change is hard. That's hard to do in an every other week landscape when all those same stressors are invading them in the 2 weeks in between. And so you're kind of always just in a recovery cycle, right, of trying to kind of navigate that. And so, it's why we are working on trying to delineate, right, between who wants service and who, for lack of a better way of saying it, needs it the most. That doesn't mean we say no to anybody, but how do we gradiate service so that the folks who functionally are having the most difficulty get more service than folks who functionally aren't? And so, that's the way that my world views it. I mean, just my brain, and I think that it is not the way that historically college counseling centers have viewed them. I will say that, right? The college counseling center model in lots of places is we see the kind of easy stuff and we refer the hard stuff out. That's been a pretty predominant counseling center model for decades, from a scope of practice and lots of other things. However, it's, to me, the absolutely wrong view from a functional and retention management standpoint. When you're now dealing with folks who are struggling at all the levels students are that you're talking about, the only chance they have is to be seen on campus, because on campus, we know all the other resources to connect them to and to tie them to that they also may need. We know the other players involved, right, in whatever it is they're struggling with and deal with. And we're able to kind of wrap around what we would really call wraparound service. And as part of what the Dean of Students Office and my office are currently doing now in a case management way, that we're then able to help make sure that they're getting care across campus to help mitigate some of that struggle. And so, to me, that's the only way to come at it. We're in a process of fully getting there. I will say now, though, students who need consistent treatment currently can get it. It's just getting them here sometimes too, right? Because the other problem that we see a lot of the time is if folks have come in with mental health treatment, most of the time it hasn't been great. I'll just be honest, because there are a lot of pretty lousy providers out there, just like there are a lot of decent ones. And they've been in systems that are not super effective, and where they don't get seen very often because those systems are taxed, and where it takes a long time to get in. Actually, I was just reading some information on a student who had to medically withdraw this past semester, and I think it had been almost 2 months, and they're still on a waiting list for individual wherever they are. The reality is the external systems are even worse than ours in terms of being able to manage and navigate some of this. So in some ways, we're so lucky. I mean, I'm going to be honest with you. But no, it's a huge issue. And that's how we're starting to try to get there, which is really looking at each person. What is it they need to be successful, and can we help provide that, right, in some form or fashion? Sorry, that was a long answer, Ramin.
I liked it.
Oh, well, thanks. Other thoughts, questions, or what can you do in your little part of the world on campus? Either any of those would be great.
I do think we need to do a better job of reframing the roles and responsibilities of our counseling center for our campus, because I mean, I'm in the old model of, you would be seen, but then, you mostly just referred to some outside. And that change is a huge change. I mean, I don't know until this moment, I really had my mind around it. So, and I'm supposed to know some of these things. So I think we got to market this differently, perhaps explain it better for our campus. So, there are contexts in which I'm able to do that. I'd be happy to, but I think, you need a big, this is a paradigm shift. I mean, at least I'll characterize it that way, perhaps.
Well, and I'll say this too. It has been quite a while at the center since that was the model. We have not had a waiting list at the center in several years, a lot of years from my understanding. But I still, even in my first year here, heard people talking about wait lists. We haven't had them. Even in my predecessor's time, Kate with Liga, they didn't have them then either. So like those are hard narratives to unravel, I will say, no matter how much we talk about them. But I don't disagree with you either. I think that that's part of it for sure, though, is continuing to do that. But I will say I've said that for a year and I still hear it. So there's almost, but I also think we also equate sometimes getting an appointment the minute I want it to a wait too. There's some of that we have go on. Some people feel like they're put on a wait list when no, they just can't get seen till tomorrow because they're actually not in crisis. I mean, so there are those factors that come into that. But no, I completely agree with you, Ramin. It's one of the things that I keep trying to talk about some that hopefully is getting better, but we need to keep doing. I'm looking in the chat here. Thank you, Alyssa, who wrote there. I'm just reading it all. Yeah, I would agree with everything, right, that you wrote in there. The more we just normalize that when what they're dealing with is normal, when it is, when we can normalize that and encourage them to use their resources that sometimes include us, right, and sometimes include you as a way of navigating that. I mean, I think that makes perfect sense. Other thoughts, questions? Anything it brought up for you? I'll warn you that I'm a therapist. I like silence, so I can sit for a little while here while we wait.
So since nobody else is talking, I'll bring up something else. So as you know well, Lynn, we've experienced some behaviors by students that were perhaps induced by laced marijuana and other things that, you know, we couldn't understand, we couldn't process, but we've seen enough of it, and the city of
Yep.
Oswego has seen enough of it. And I think you may be in a better position to talk about it, but we've seen it enough that maybe it's worth talking about.
Sure. Yeah, I think that the Dean of Students Office, and I know that that Kathleen, VP for Student Affairs, I know that we're trying to figure out some ways to message it. But we definitely have. I warn every student that I speak to who's using cannabis that they need to be very careful. There's definitely something happening in the community and on campus. I think we had, I feel like it's at least 7 students last semester. Almost all, I think, had to medically withdraw because of psychotic reactions as a result of what we're pretty sure now, and what the hospital is pretty sure now, is a result of cannabis use, probably in laced cannabis use. Those are not symptoms that are going away once their high ends. Those are persisting. And so, you know, it's been very hard to pin that down. There's no like community mental health statement or anything that we can kind of vie onto, but we're seeing it enough that it's definitely a concern. You know, those are times we need to intervene. Those aren't the times that, so I would, you know, I don't know if I'd call that quite a crisis, but we're probably on the edge of that, right? That's a problem that we need to figure out in a specific way how to solve. That's very different from this overall notion of a mental health crisis that we have. But yeah, there's definitely that happening right now out there. I'm reading. Give me just a second, Lisa. Okay, thanks. So how do we navigate somebody who says they have mental health issues when you're not, you know, a mental health professional, as it were? You know, I think it's really simple. I think that it's understanding what that means. And, you know, just because I have mental health issues doesn't mean you can't help me with the stress I'm having about this class, for example, right? Or just because I'm having mental health issues doesn't mean you can't help me think through what my options are and how to navigate this problem that I'm having. And I think that, and it doesn't mean just because I have mental health issues that you can't still give me feedback that I don't really like to hear necessarily. That, so, you know, and it doesn't mean you have to explore what they even mean by mental health issues. I'm going to say that too. I don't think you have to worry about what those words even mean, because I think that, you know, anxiety, that's not I mean, it can be a diagnosis. It's also just a state. Anxious is also just a state. So I don't think anxiety is one that you have to worry about at all necessarily in terms of falling into a clinical realm, unless you're trying to help them manage it, you know, or treat it, so to speak. But I mean, my gosh, if you can't help a student who's anxious calm down, I don't know what we can do. I mean, how many of those do we all get, you know, on a fairly regular basis? You know, we all can know some basic de-escalation things, right, that help people calm down. We all can ask questions about how people are eating and sleeping to see if their basic needs are, you know, getting in the way of how they're functioning. And by the way, if students are having a lot of trouble sleeping, that is when you can send them to us, because we can help deal with sleep. Sleep is a huge predictor of struggle. And so we have lots of students that are sleeping well, lots of times, back to Ramin's point, because of trauma and other things, right, that are making it hard for them to sleep. And so sometimes that sleep piece is a bigger symptom of something that we need to evaluate. But I think in general, even for me, when I've got somebody coming in and they're leading with all my mental health issues, I'm going, okay, let's understand what that is. Because a lot of times it isn't what my brain thinks it is. It's not mental health issues the way I would define it, right? It's in this bigger general social current cultural atmosphere of what it means. And lots of times they're just distressed or uncomfortable. Or they've diagnosed themselves because they've seen it on TikTok or whatever. I mean, we've got all that happening too. And so I think it's not getting too worried about that. I think it's instead understanding, okay, when do I refer? If I think somebody is at risk, I better refer. If this is something that we've had a conversation about 2 or 3 times and it doesn't seem to be getting any better, or it seems to be getting worse, maybe we suggest something else. If this is a situation that I'm doing my best and it isn't calming, maybe I need to, right there. I think maybe it's looking at it from that perspective. But most of us have some just basic skills of being able to kind of listen to people. Hopefully, not all of us, but most of us are decent at it. If we think about it in our personal lives, can I just listen and understand it enough so that I at least have information to make a decision, and not getting as wrapped up in the terms as what's actually happening. Understanding what those terms mean for that person, I think is part of it. Because just because a person comes in and says, oh, I've got a bipolar diagnosis, which may be legit, may not, it doesn't even matter. That doesn't mean I can't help them with what's stressing them out today. Because maybe that problem is in my wheelhouse, right? And so I think it's kind of thinking about it. Hopefully that's helpful in those ways, and not being afraid of those terms, but instead understanding what they mean by them, and is it even relevant in this moment? Does it, I don't mean does it matter, but if I'm struggling in a class, and they're going to talk about their mental health issues, that I'm just going to ask, how do you think that's interfering? I'm going to learn a little, and then it'll help me figure out, is it a really interference and they need more treatment, so we would do a referral to the counseling center, or maybe they're just not studying using the study skills that would be most helpful, and I can help them with that. And so dialing in on the real problem, I guess, is the way my brain would go to it. And Lisa, is that helpful? I can see your face now. Is that a helpful response?
It is. I'm thinking about the trying to normalize it when we know it's not a referral situation, but the student, I have a student, the one in particular I'm thinking about, who in my time in my current role has withdrawn in the middle of 2 consecutive semesters. She just came back this fall was her 3rd semester attempt since she was with me. She finished this semester, but then sent me an email as soon as the semester ended that she will not return in the spring due to mental health issues. And every meeting I had with her, she referred to her mental health issues as hurdles.
Yep.
And so without probing and asking questions, what do you mean by your mental health issues? She never seemed in crisis to me where I needed to refer her, but trying to help her, trying to normalize whatever I don't know what her issues really were, but trying to help her learn coping mechanisms and understand that school can be hard. There's stress, you can do it. That's, I think, where I was going with that. And
yeah. Well, so I'll expand maybe a little further even. I think that if a student has had to withdraw multiple times, then and they're talking about mental health being the significant reason, the question that I'm asking is, who are you seeing to help deal with whatever those issues are? What services are you accessing? Because kind of right definition of insanity, continue to do the same thing, expecting a different result, right? So we want you to be successful. What is it you need to help manage whatever those issues are, so that you are feeling more equipped to navigate your semester and be successful? Because that's what we want you to be, right? And so you don't have to be the mental health expert to problem solve that piece of the puzzle. And if and lots of times what you see and what I have seen is somebody who's in that cycle who's still not doing much of anything actually to navigate whatever the mental health issue is. And it's not also even always lack of resources. It's just it can be a whole host of other things. It can be time, or thinking about it, or calling to schedule the appointment, or it can be a whole host of things, right? That in their mind at the time are barriers to why they haven't. But most folks who are in a cycle of withdrawing are probably not in treatment, are often not. And if they are, then it lends, and if they're like, no, I've been seeing a counselor, every week for whatever, then what I always ask is, are you talking about the struggles you're having in school there? Right? Because lots of times they're not. And so that's why I think for a person who's in that kind of cycle, it's different for you because they're on Syracuse campus, that we're getting a resource for you that they can use in a little more active way. But it's why if it's on campus, I'm like, no, that's the folks that need to come see us. Because if you're in a cycle of withdrawing and you're saying it's due to your mental health, then we should be assessing that and figuring out what you need to mitigate that. Whether you have an official diagnosis or not, I don't care. It is doing nothing but hurting their overall mental health to be in that kind of cycle. Because that cycle does not feel good for anybody. And quite honestly, for many students is starting a SAT problem, an academic progress problem, or a financial problem that they're gonna have a ton of trouble digging out of. So those are the things I think we want to avoid. Was that more helpful?
Yes, thank you.
Other questions, anything like that for the 2 or 3 minutes that we have left? I'm going to flip to this slide. That's why I left it up. If you're interested in reading more just about this issue, it's more about the mental health kind of strategic planning and what's happening on the mental health landscape right now. If you were to Google navigating a path forward for mental health services in higher ed, you will find the position paper that myself and three other colleagues co-authored last year. That feel free to reference that if you'd like. Any other questions as we wrap up, or thoughts? Okay, I'm going to assume there's none. I want to thank you all so much for your time and for stopping in today. If you want to hear if you want to listen to me again or hear any more information, on Friday, I'm going to be doing a session on understanding the impact of trauma and bias incidents on learning. So feel free if you want to pop into that. And if there's any information I can ever provide you individually, don't ever hesitate to reach out to me. I'm going to pop, just in case, I think everybody should have it, but just in case, I'm going to pop it in the chat. If I can type and talk at the same time, which I can't today. There we go. Don't hesitate to pop me an email if you need to. And I'm happy to come and speak to you or your department, or just send you some info, whatever you would find helpful. So don't hesitate to use me as a consulting resource here as you move forward. And thank you all. I appreciate your time. Hope you have a great rest of your day.
Thank you.
Thank you.